prescribed to people with depression, alcoholism, Parkinson's, and obesity. The public caught on to methamphetamine pretty quickly and began to use it to stay alert or for losing weight. It eventually began being heavily used by certain groups of people, especially truck drivers and motorcycle gangs, and then found its way into the gay community in the 80s and the 90s. Next slide. Next slide. So my quick outline for this presentation is I'm going to describe what meth use looks like among Black MSM across studies and what the weight of the evidence has been. Talk a little bit about the drug use patterns among Black MSM and how that compares with Black heterosexual men. And then I'm going to get into a small discussion about other considerations and issues. Next slide. So across studies, you see less meth use for Black MSM, and it doesn't matter what type of study it is, cross-sectional studies, prospective studies, it doesn't matter the size of the study, if it's a large multi-site study or with thousands of men, or small studies with only a couple hundred men. And it also doesn't matter in the period of time that the data were captured to report meth use. So this first slide is meth use in the past 3 months. It's from one of my studies that I did while I was still a scientist at CDC, where we had Black MSM as well as Latino MSM from 4 sites nationally. And as you can see here, Black MSM were less likely to report meth use in the last 3 months. Next slide. And then you also see the same thing in San Francisco. These are data from their national behavioral surveillance from San Francisco in 2005. And you could see that in the past 6 months, Black MSM were also less likely to report meth use compared to other MSM. Next slide. And these are data from Miami, where again, Black MSM were less likely to report meth use compared to other MSM. And this time the reporting period is the past year. Next slide. And then also, when you take a look at the past year for a larger data set, this is a national HIV behavioral surveillance system that takes place every 3 years that CDC has been doing since 2002. And this is from the first wave of data collection, where you see that Black MSM were less likely than white or Latino MSM to report methamphetamine use within the past year. Next slide. And when you take a look at NHBS between 2008 and 2014, these are new data that they just published. They found that there were no significant differences across all of the sites. This is about 22 cities across the United States where they report data on MSM. There are no differences overall in terms of meth use from the 2008 data collection, the 2011 data collection, or the 2014. However, what they found is that in each year, meth use was more common among MSM who were white, who had a high school education or less, made less than $20,000 a year, or lived in Western cities and were HIV positive. And when you take a look at the right of the slide, you could see the 2008 NHBS cycle and the 2011 NHBS cycle and the data that are there. And for each cycle, Black MSM across NHBS were less likely to report meth use. Next slide. And even in studies that I've published, I published a study back in 2012 where we looked at all the accumulated data that compared Black MSM and white MSM across substance use. And at that time, there were 33 or 34 studies that had been done where we were able to get data. And you could see that Black MSM were less likely to report any lifetime drug use, recent drug use, any recreational drug use, any drugs that are associated with HIV infection. And press on the next slide. And Black MSM are also 60% less likely to use methamphetamines across all studies. And this is all the data that we have for Black MSM compared to white MSM by 2012. Next slide. And unfortunately, or rather fortunately, you find the same thing for young Black MSM. Across all studies, young Black MSM, next slide, were 90% less likely to report any methamphetamine use compared to young white MSM. Next slide. And what you see when you take a look at the Black community overall, and this is what's happened traditionally, is that the Black community overall, Black MSM mimic the same patterns that African Americans overall have in terms of drug use. And this is a slide from Los Angeles County where they compared Black MSM who are in, I'm not sure if it's showing up here, Black MSM with heterosexual Black men. Black MSM are the yellow bars and heterosexual Black men are the red bars. And what you can see is that the bars are fairly comparable, whether it's alcohol, marijuana, cocaine, crack cocaine, that black MSM and heterosexual men are fairly similar in the types of drugs that they prefer and in terms of the use of those drugs. Next slide. However, some of that started changing back in 2006 and perhaps a little bit earlier. And this is an excerpt from our article from the New York Times, where they're talking about meth really creeping into the black community. And Perry Halkitis, who's on this call, was really among the researchers who were at the forefront in identifying what was taking place. And, you know, what the article described is that at a methamphetamine support group by Gay Men's Health Crisis, that blacks were now more than 10% of the participants, and that was up from fewer than 2% just years earlier in 2001. And Donald Suggs, who was outreach coordinator at Harlem United at the time, said that there's little room for discussion in the Black and Latino community where the stigma is much worse in discussing or talking about crystal meth. So, you know, you saw the data that I showed beforehand where Black MSM were not reporting crystal meth use. In this article and others were suggesting that perhaps it's because of the stigma that was associated with it. And we're going to get back to that a little later in my presentation. And next slide. And unfortunately, even though across NHBS you find that Black MSM are less likely to report crystal meth use, what you find here in Washington, D.C., just from the Washington, D.C. National HIV Behavioral Surveillance Site, is that between 2008 and 2014, crystal meth use reporting decreased among white MSM, but you see a huge increase here between 2008 and 2014 for Black MSM. Next slide. And we also know that there have been anecdotal studies about Black MSM who were introduced to crystal meth from MSM communities that traditionally had been more involved in crystal meth activities. And unfortunately, we have a case of a young Black gay man who just in last month died after overdosing from crystal meth use after being introduced to it allegedly by a wealthy white gay man, and this happened in California. And to the right is an excerpt from the young Black gay man, his name is Jamel Moore, from his diary, where he said, "My life is at an all-time high right now, and I mean that from all ways. I ended up back at Buck's house again," that's the name of the guy on the right, "and got manipulated into slamming again." Slamming is when you're actually injecting crystal meth into your body. I even went to the point where I was forced to doing it four within a 2-day period. This man is crazy and it's sad. Will I ever get help? So this is, you know, one of the larger, higher profile studies that has been in the national news recently of Black gay men dying from crystal meth use. But we're not only seeing Black gay men introduced to crystal meth use from white gay men, we're seeing that within social networks that are just Black MSM, and this is different from 5 and 10 years ago. For those social networks that are just Black MSM, that crystal meth use is increasing, particularly at sex parties and other places. Next slide. So there's a couple of things that we have to consider when we talk about Black MSM and meth use. Next slide. The first is that meth use actually varies across communities of Black MSM. Next slide. So these are data from CDC from the 1990s. And one thing that you see over and over again is that amphetamine use is higher on the West Coast as compared to is on the East Coast. And that's for many different groups. And you saw the same thing for Black MSM, where in the CDC's data, meth use, amphetamine use was higher for Black MSM who lived on the West Coast versus Black MSM who lived on the East Coast. Next slide. And when you took a look at the data from the Young Men Survey, and remember this is a large survey of about 6,000 MSM from all across the country, you see that Black MSM were less likely to report meth use compared to white or Latino MSM. But that's not necessarily the whole story, because what the researchers did here was take a look among Black MSM to see if there are any differences in reporting meth use or any drug use among Black MSM. Next slide. And what the researchers found is that those MSM who were Black said, who said that they were Black, as compared to those Black MSM who said that they were mixed race, that Black MSM who are mixed race were more likely to report meth use compared to Black MSM who said that they were not mixed. And this is something that I discussed quite a bit while I was at CDC and at other places, and I'm actually surprised that other researchers haven't looked more into what other dynamics are taking place here for mixed race Black MSM. Next slide. And it's not just meth use for mixed race Black MSM. Next slide. The researchers found that across all types of drugs, that mixed-race Black MSM who were younger were more likely to report injection drug use, shared needles, uppers, speed, powder cocaine, crack cocaine, nitrites, which is, poppers, compared to those Black MSM who said that they were Black only. So there's some differences that we're seeing even in some of the data among Black MSM and meth use. Next slide. And it's not just meth that is a worry to us. Next slide. We know that there's a sharp rise that's taking place right now in the middle of the opioid epidemic, and the opioid epidemic is primarily affecting white communities nationally, but we're seeing sharp rises in African-American communities in specific places in the nation. And the Washington Post just recently reported on a rise in opioid epidemic overdoses among African-Americans in Cleveland. And you can see here from 2014 through 2017 that there's been a precipitous rise in overdose deaths among African-Americans in Cleveland. Next slide. And in another analysis that was done by the Washington Post, a lot of these deaths are being fueled by fentanyl. And fentanyl is a synthetic drug, opioid that many people are lacing in heroin. And you can see here that fentanyl deaths have been increasing in many of the cities, and primarily African-American cities in the United States. So in Baltimore, in Cleveland, where we see what I was talking about beforehand, in Philadelphia, Washington, D.C., we're seeing these rises in fentanyl overdose deaths between 2014 and 2016. So this is not just a rural phenomenon in terms of rises of opioid deaths. We're seeing these in cities where there are large African-American populations. Next slide. And unfortunately, we're also seeing this in the NHBS data among MSM. So when you take a look at the NHBS data for opioids between 2008, 2011, and 2014, in each year, opioid use was more common among MSM who were white, young, had a high school education, $20,000 or more, or who lived in Western cities. So it's very much the profile that we're seeing with meth use. Next slide. However, when they took a look at this by race and ethnicity for opioid use in the NHBS data, you could see for those first three bars on the left-hand side that between 2008 and 2014, there was a huge increase in meth use for Black MSM. So it went from 4% who said that they were using meth to 6% within that period of time. And when you take a look among white gay men, even though white gay men were more likely to use opioids, I'm talking about opioids, not meth, even though white gay men were more likely to use opioids, you see a decrease in opioid use between 2008 and 2014, which is very different than what we're seeing with Black MSM in the CDC data, where we're seeing this increase in opioid use. This is something that's really problematic for us. Next slide. Because the NHBS also found that across the 2008 and 2014, that racial disparities in HIV infection are actually increasing between Black MSM and white MSM. And those disparities, next slide. Those disparities are actually greatest among younger MSM. And that's what that yellow box is showing, is that you see that spread in disparities between HIV infection between white and Black MSM is actually growing larger for younger MSM. And what some of that is, probably showing is what's taking place with opioid use as well as methamphetamines in the Black community, where these disparities are getting larger, as well as Black gay men getting left behind in terms of access to healthcare, either for PrEP or for HIV. Next slide. So the last thing to consider is whether or not Black MSM are underreporting meth use. Next slide. There are actually data that Patrick Sullivan and his team did in Atlanta, where they published this recently, where they were looking at a sample of Black MSM compared with white MSM. And what they found is that among those men who were urine samples found that they had used cocaine recently, that more white MSM were likely to report that they had used cocaine compared to Black MSM. So among those where the urine samples confirmed that cocaine use was used recently, 84% of white MSM said yes, they used cocaine. Only 54% of Black MSM said that they used cocaine in the last 6 months. Next slide. So Black MSM were 36% less likely to report cocaine use compared to white MSM. Next slide. And one of the other things that they did that I thought was clever is that they looked to see whether or not arrest rates were different for Black MSM and for white MSM. And of course, they were different. Black MSM were more likely to have ever been arrested compared to white MSM. But you found a similar pattern of underreporting cocaine use, even among those MSM who've been arrested. So when they looked at the urine samples of those MSM who had ever been arrested, again, white MSM were more likely to say that they used cocaine in the last 6 months and was closer to the results that they found in the urine. Black MSM were not as likely to report cocaine use. And it was not just for arrest, it was for younger Black men, it was for older Black men, it was for Black men irrespective of socioeconomic status, where we saw this systematic underreporting of any type of drug use over the past 6 months. So one other thing that we need to consider is with all the studies that have been done from now until 20 and 30 years ago, whether or not there has been systematic underreporting in the Black community and Black gay men for some of these substances, and that we're only now starting to detect some of this because of these high-profile cases like Jamel Moore, or even some of the data that we're seeing from NHBS from here in Washington, D.C., where we're seeing these increasing cases. So with that, I'm looking forward to hearing the discussion, and thank you again for your attention.
Thank you so much, Greg. So our next presenter is Dr. Perry N. Halkitis. Dr. Halkitis is Dean of Professor of Biostatistics and Social and Behavioral Health Sciences at the School of Public Health at Rutgers University. He's also a faculty member of the Cancer Institute of New Jersey. Dr. Halkitis' program of research examines the intersection between the HIV epidemic, drug abuse, and mental health burden, and the biological, behavioral, psychosocial, and structural factors that predispose these overlapping epidemics. CHIBS, C-H-I-B-P-S, the research center he founded, conducts cutting-edge biobehavioral studies, serves as a training site for the next generation of scholars and partners with community agencies to conduct studies for and with the LGBT population. His last book, The AIDS Generation, Stories of Survival and Resilience, is a 2014 Lambda Literary Award nominee and recipient of the American Psychological Association Distinguished Book Award in LGBT Psychology. Author of over 200 peer-reviewed academic manuscripts, Dr. Halkitis is also often cited in the press. Dr. Halkitis is the editor-in-chief of the journal Behavioral Medicine and serves on numerous other editorial boards. He's a recipient of numerous awards from both professional and community-based organizations. He's an elected fellow of the New York Academy of Medicine, the Society of Behavioral Medicine, and in 4 divisions of the American Psychological Association, and is a member of the Nation's Well Council and Who's Who in America. Again, if you're if you've joined in the middle of this presentation, the presentation will be made available shortly after it's completed. So if you're unable to be on the entire time, it is no worries. We can get it over to you. So looking for Dr.
And while you're looking for my slides, thank you for—
Oh, you're there. No.
Thank you for the introduction.
Okay.
That's wonderful. Thank you. And I really appreciate the opportunity to speak after Greg, because I think Greg alludes to many of the things that I'm going to be exploring, the themes I'm going to be exploring with you in the next few minutes. And I guess I want to start by saying, there's lots of questions we could ask here about meth use in the Black population of gay, bisexual, and other men who have sex with men. But ultimately, I want to like sort of trigger this thought in your brain, which is why substance use at all? And why, it's not just about the substances people use, but why is substance use so prevalent in the gay population to begin with? And why is it so prevalent in the Black gay population? And I come to this conversation with a full understanding that when we talk about substance use issues are not separate from psychological issues. They're not separate from societal issues. They're not separate from sexual issues. And that all of these things go together, and it's not a simple unidirectional relationship. And so when we try to treat one of these things, we have to treat the whole person. And I put that up front as the beginning of the conversation. Next slide, please. Right. So what I'd like to do in the next few minutes is basically talk a little bit about the patterns of meth use in a diverse samples of Black, gay, bisexual, and other MSM, talk a lot about what I think some of the drivers are of meth use, the associations of meth use and sexual risk-taking, and then potentially an approach for addressing meth and other drug use in the Black MSM population. Next slide, please. And so I start with this quote. So I was at a conference in 2003, which is a long time ago, in a very beautiful location. And it was a conference about meth, one of the first conferences about meth that had been sponsored at the national level. And the person, a very prominent person in the room, made the following point. Meth will not become a major problem in the Black population. A Black individual has a different allele structure than white individuals. It should say "as" there. And I was quite shocked when that was said. And I thought, and my response was, well, I think that's completely untrue. And at that point in time, what we were seeing around about meth use in the gay population was really a pattern of use among middle-class white men. But it was pretty obvious to me, given the properties of the system, that it was only a matter of time before certainly the drug would spread to other parts of the population in my New York City, as well as other cities around the country. And I make this point because I think when we're thinking about meth use, we can't just be using a biomedical approach to treating this drug addiction, but rather we need to espouse a biopsychosocial approach where we think about biological factors interacting with psychological factors, interacting with social factors. And a drug like meth is so driven by psychological and social realities that it is short-sighted to think about it purely in a biomedical way. Next slide, please. And so, as Greg has said, has indicated, crystal meth, was a street version of methamphetamine that emerged in the late 1950s, early 1960s, when the prescribed drugs began to be taken off the market. I think we're seeing a similar thing with synthetic opioids. When you have a prescribed drug and you prescribe it to the population, and then you just sort of rip it out of their hands, people who are addicted to the drug are going to continue to use it. So crystal meth developed in the crystal meth became a street drug in the late 1950s and early 1960s. It is a powder that goes by a variety of different names, such as Christina or Tina. It is used in a variety of different ways. Most often people begin by snorting it. Eventually, if they are addicted, they become injected to it. Next slide, please. And this is a drug that is, sometimes people ask me, if as a harm reductionist, if somebody was going to do cocaine or meth, what would I tell them to do? And of course, my first reaction is neither, but I'm a realist and also realize that some people use substances. And if you were going to use a substance, cocaine versus meth, cocaine is probably a less harmful substance to use, because when we look at the picture that you have in front of you right now, it is a depiction of the various harmful toxic products from which methamphetamine is actually made. Next slide, please. And it is made in labs such as this, which are very makeshift and which not only create environmental hazards, but also create very dangerous conditions for people living in the vicinity of these labs. Next slide, please. The effects of meth are not always immediate. And I have this illustration here for you to just see the face of an individual who had been using meth for 10 years, who started using at 28 years old and eventually died at 38 years old. And you can see over the course of a 10-year period, of a decade, what happened to this particular individual, just to their face, which I think is a very clear characterization of what was happening to that person psychologically and physically. Next slide, please. The effects of meth are many parts of the body. We know there are enormous effects on the cardiovascular system. There are reported cases, there are documented cases of individuals experiencing strokes. There's the effects on the respiratory system. There's the effects on brain and on the nervous system. And these effects have these physiological effects impact an individual's social well-being, physical well-being, and mental well-being. Next slide, please. But so why do people use this drug? Like, if it is so bad, and Halkitis is telling me here it's so bad and it has all these bad effects, and what's the draw? And from a chemical perspective, this is what happens. Methamphetamine is a drug that stimulates production of dopamine in the brain. And dopamine is a neurotransmitter which causes a feeling of beauty and wonderfulness. It is the feel-good neurotransmitter. Methamphetamine has the ability to not only increase the level of dopamine in the brain, but but it also blocks the reuptake of dopamine in the synapses, meaning that the dopamine resides in the brain for a long period of time. And so as a result of that, in these synapses, as a result of that, feeling good, feeling on top of the world, feeling beautiful, feeling amazing are all the psychological effects of using this drug. And if you can imagine with me for a moment, an individual who's being stigmatized for lots of different aspects of who this person is, because this person is gay, because this person is Black, because this person comes from a low economic level. If you think about a life which is compounded by all these forms of stigma, and where there are no sources of support to help ameliorate those effects, then this drug provides a very easy, quick fix to feeling good about one's life, which is sometimes not so wonderful feeling. Next slide, please. And so, so at CHIPS, we've studied meth use for like close to 20 years now. These are just some images from our studies. Next slide, please. And some of the studies have focused specifically on meth use, and others have been more broad and all-encompassing. The first study we did in 1998 was Project Tina, a cross-sectional study, a very small study. I put this demographic snapshot up there for a reason, because what I had seen over the course of the last 20 years, and I think Greg alluded to this also, is that while initial studies in the 1990s and the early 2000s did not demonstrate a high level of use among Black MSM, we see increasingly across time a larger number of Black men reporting, maybe still underreporting their meth use. But the most recent studies that we have undertaken at CHIPS, the largest portion of the sample are Black, often HIV positive men who are using methamphetamine. Next slide, please. And so I'm just going to present some of the major findings from Project Tina, because I think the relationships between social, psychological, structural factors that came out in this study are as true today as they were in 1998. Next slide, please. So one of the things that we found, and what we see pretty consistently among meth users, is that very often this is a drug it's used on the weekends. It is a party drug. It is a drug that is associated with downtime. Unfortunately, because of its effects, it tends to spill out into affecting one's week. But it is a cycle. It is a cycle of partying. This is not to say that individuals don't eventually become chronic users, but for the most part, and we don't know this because we don't have real epidemiological data on gay men, it is a drug that is often a drug that is focused on concentrated periods of time of high levels of socialization. Next slide, please. And this quote from Bob depicts it perfectly. When he says, "I'm probably using it once every 2 weeks, something like that, generally on the weekend, either, I guess, under two circumstances. One is whether at the Bats or if somebody comes to my apartment and we do it there." Next slide, please. And we know that there is an enormous association between methamphetamine use and sex. And in Project Tina, most of the individuals who are using meth indicated that they were using it because of sex. This is a hypersexual drug. And so the question really becomes for us, I've thrown out some ideas there about like multiple levels of stigma that our people are experiencing as potential drivers for meth use as a means of coping with those feelings. But another question I want to throw out for us to consider is the desire for a certain kind of sex another driver for meth use? Because with use of meth comes a reduction in inhibitions. And with a reduction in inhibitions comes an ability to act in ways that one might fantasize about. And so the question is, which comes first, meth use or desire for certain kinds of sex? Next slide, please. And here's what John says: "I find that my experience of crystal is very context specific. Taking it at the Bats is very different from taking it in my apartment with one other person. I think my sexual experience has changed somewhat to profoundly over the time. I find the sexual experience on crystal quite different from sexual experience without crystal. I find them more interesting and engaging." And here is one of our challenges. There is no robust intervention. There are some interventions that deal with meth use, but the problem we are facing with meth in the gay population is the psychological addiction to the drug. And for gay men, many of whom, or some of whom, or a proportion of whom, define their identity in part by their sexuality and the sex that they have, taking away a drug which enhances their sexuality creates a psychological roadblock to actually quitting the drug. And so meth users who have stopped using meth will often tell you that the kind of sex they had while high is nothing like what they experience after they stop using meth. And so we find this pattern of falling back simply because of a desire to have this outlandish, what is perceived to be amazing sex. Next slide, please. And let's never believe that meth is used alone. This study and many of the other studies we have done have shown that, in fact, polydrug use is the reality for most gay men. Meth is used with a variety of different substances, including erectile dysfunction medications, as a means of being able to have sex, because meth actually causes erectile dysfunction. But combining meth use with erectile dysfunction medications like Viagra allows individuals to be high, to feel great, and to have endless amounts of sex. Next slide, please. And so Paul says, I mix and match with other drugs, definitely marijuana, you know, alcohol, cocaine sometimes. It just depends. It depends on what's available at the time and where I am. Next slide, please. And not only does meth enhance the number of partners with which an individual has sex or the frequency with which individual has sex, but in this study we found that it allowed individuals, it permitted individuals, it gave permission, I use a lot of different verbs I could use here, to have different kinds of sex other than more traditional forms of sex, including group sex, sex with toys, S&M, and felching and fisting. Next slide, please. So why use meth? Why use club drugs and why use meth? One of the analyses we did from another study called Project Bumps really came up with three main domains that drove drug use in the gay population. The physical domain, including sexual sensation and physical sensations. Next slide, please. The emotional domain which included cognitive disengagement and the desire to escape. And next slide, please. And this one's really important for me, social interactions. And I think it is incredibly important for us to realize that being a gay man is challenging in many ways. And I and others as gay men are often raised in families that are not understanding of our sexual orientation. We feel different and other-like for much of our lives. And what ends up happening too often, unfortunately, is that we leave those homes, even if they're loving and accepting, and find ourselves in a community which unfortunately at times can be as stigmatizing. And for Black gay men in the gay population, that form of stigma has to deal also with their race. And so I think we need to take ownership as a population of what we do to ourselves and the kinds of behaviors we sort of, you know, engage in, that, and the kinds of ways we interact with each other that makes substance use such an important factor in being able to overcome our social inhibitions and motivate and be with each other. And so I throw back to us as a population, you know, what our responsibility is for being accepting and loving and non-judgmental of each other, the way we look, how tall we are, what our weight is, because that makes it all the more worse for us as we're trying to find a place in the gay population away from our families. Next slide, please. So another study we did shortly thereafter was a study and I want to point this one out because I think it's because it makes a certain point. It was a Project Pump, which was a study that looked at the behavior of individuals attending gyms. Next slide, please. And what we did was looked at a gym, people who were recruited at gyms, and you know, the funder of this study indicated to us that they thought that we would see much more healthy behaviors of the gym attending sample. And I sort of chuckled under my breath and I said, well, but you know, the gay men often go to the gym to be able to go to the bars and the bathhouses afterwards. So I don't imagine that we're going to see less substance use. And as you see in this slide, we didn't. And next slide, please. And in this study, we saw at that time, which is a paper, this is around late 2000s, a variety of different ways of using meth, lots of inhalation, inserting in the rectum, certainly smoking. I do believe now, and there is some anecdotal evidence to indicate that injection use of methamphetamine is on the rise in the gay population. Not normally a behavior we see highly prevalent in the gay population, but one that may be on the rise, and certainly one that we should be aware of as we're dealing with this problem. Next slide, please. And in this particular study, what we found was that the Black men and the Hispanic men and the HIV positive men were all more likely to be using methamphetamine than the Black and Hispanic men, than their white counterparts, and the HIV positive men than their HIV negative counterparts. And moreover, those who defined their masculinity in terms of sexual behavior who had higher scores on that particular construct also had a higher likelihood of using meth. Next slide, please. And next slide, please. And this was another study, and I'm just going to go through this one very quickly. This is the most recent study, and as you can see from this study, this is again a convenient sample. But even though it's a convenient sample, it tells you something about what the usage may look like in the population. This was only a few years ago, and what we saw in this particular study of 100 men was the majority of the individuals we recruited were Black men, and the majority were also HIV positive. Next slide, please. And two more points here is that the XY relationship between meth use and HIV is not that unidirectional. If you just click it one more time for me, right, and one more time again, thank you. What we find is that there is certainly a tendency for individuals to use meth and then seroconvert, but meth is also used by HIV positive people after they seroconvert. And what we argue in this paper that we wrote based on this data set is that for HIV positive people, meth provides another way of coping with another challenge in their lives, which happens to be HIV. Next slide, please. And so this all led us to do a study called Project Hope, which is a study that's focused primarily on African-American gay and bisexual men. Next slide, please. And just very quickly here, in this very small study, we found that participants were using meth about 8 times a month. Again, that's a weekend behavior. They were about 33 years old. They spent a lot of money of the money they had on drugs, but on meth, but other drugs also. About 40% of them had traded sex for meth. And they had done so. Those who had done so about 4 times. Next slide, please. And what's really interesting to me is that despite the fact that all this money was being spent on meth, so now we have this economic conditions too, that the men who in this sample were not making a lot. We're not making a lot of money, and as a result of that, they were their lives were being further compromised by the challenges of a drug that they were using in terms of their economic means. Next slide, please. And this is just a map of New York City, which showed, if I can't point to it, but in the long part on the left-hand side is Manhattan, and downtown Manhattan is traditional gay neighborhood. But what we saw in this study is that meth users came from all parts of New York City, including the Brooklyn, the Bronx, and Upper Manhattan. And that's an incredibly important point to sort of disentangle this mythology that this is just a white gay man's drug nested in gay neighborhoods. Next slide, please. And so for Black men, we did an analysis of what the interview data told us also, and we came up with this sort of heuristic here, which basically showed that based on the interviews we'd done with these men, that challenging childhood and developmental situations, and including trauma around sexual identity, led to pressures not only from their families, but from the gay community itself, pressures to conform to hegemonic images of Black masculinity, and experiences of triple isolation from the white gay community led many Black men to use meth and have sexual behavior risk-taking as a means of overcoming pressures and norms, and as a means of overcoming the stigmatization that they experience within the gay population and within their racial and ethnic and cultural population. Next slide, please. And so here's one of the men said to us, meth is definitely an outlet. As far as drug is actually, it's an outlet. You don't have to be enclosed in your skin. You can come out of yourself more. Next slide, please. And so in summary, just some points here, I believe, and I'm just going to highlight the red things, that social, psychosocial, and mental health states, as well as the desire for a certain type of sex, may drive use and the ultimate addiction to this drug. Next slide, please. That methamphetamine use and HIV are complex and related, and it's not a simple unidirectional relationship. Meth does just not simply lead to HIV, but these things happen holistically and synergistically. Next slide, please. And isn't the real question, why is any drug use so prevalent among sexual minority men, and specifically Black sexual minority men? That's what I think we should be asking ourselves, more than asking about the specific drug that men are using. Next slide, please. And I'm gonna let you watch this video on your own. We can go to the next slide, please. It's a really horrible picture. And so I'm going to leave you with this one theoretical framework, a theory of syndemics that argues that stigma, discrimination, homophobia, and other psychosocial burdens are often experienced by gay men, and that these drivers drive health problems, and that substance use, mental health, sexual risk-taking go hand in hand with each other. Next slide, please. And this is a depiction of this idea that I worked on a paper with my friend Greg and our colleague Rich Walitsky that basically argues that HIV and substance use need to be considered in relation to numerous other health problems, including mental health, violence, and other sexually transmitted infection. You can add many more bubbles to that bottom box, but that biological influences, behavioral influences, and psychosocial and structural influences come together to shape these things. So a biopsychosocial perspective is what we need to espouse. Next slide, please. I'm almost done here, guys. And so a model for health is one that really focuses on the total health of gay men. And I think that until recently, and I would argue that still now, current HIV prevention strategies are band-aids. We're just scratching the surface. We're not really digging deep into what the real problems are that drive the health problems of gay men. Next slide, please. And so I leave you with our website, with my Twitter and my email. And thank you very much.
Thank you so much. All right, so for our final presenter, we have Dr. DeMark Hickson. Dr. DeMark Hickson currently serves as Executive Director at Us Helping Us, People into Living Incorporated. Prior to onboarding at Us Helping Us, DeMark served as an Associate Professor at the Biostatistics in the Department of Epidemiology at Biostatistics in the newly established School of Public Health at Jackson State University, as well as Chief Operating Officer at My Brother's Keeper. Importantly, Dr. Hickson was part of the team that opened Arms Healthcare Center, the first LGBT primary healthcare center in the state of Mississippi. I think someone may have their line open. If you could just mute your line, so I'll mute everyone. Thank you. Dr. Hickson's work includes community-based advocacy and environmental and policy systems changes that are effectively informed by the comprehensive program of health disparities and health equity research into the salient life course, psychosocial, and multi-level factors that impact cardiovascular disease and its related risk factors of HIV/AIDS among racial and sexual minorities, especially in the deep American South. So without further ado, I hand it over to Dr. Hickson. Hickson?
Hi, can you hear me?
Yes, I hear you now. There you go.
Okay, great. I don't see the slides though.
Yeah, it's coming up right now.
Got you. Well, while you're putting that, I just want to say thank you to UCHAPS for inviting me to present alongside Greg and Perry, researchers who I have cited in much of my work. And so it's an honor to present alongside these two great HIV prevention researchers.
Okay, do you see your slide up?
No, I do not.
No, okay, let's try that one more time.
All right, there we go. So yes, thank you, Kenya, for the nice introduction. I know I mentioned that, well, I know that you mentioned that I'm the executive director of Us Helping Us. So these slides are based on some of the work that did in Jackson, Mississippi, while I was at My Brother's Keeper and at Jackson State University. So I'm going to kind of blend the talks that Greg and Perry have given and talk about some of the work that we have been doing in Jackson and that I hope to continue here in DC. But looking at it from looking at the use and abuse of methamphetamines and opioids from an ecological perspective and looking at the influences that neighborhoods and environmental factors may have on its use. Next slide. So as we've been talking and we know that there's a stark racial disparity in HIV incidents that persist among Black MSM, and in much of my work, I've termed this as the Black MSM paradox, where we see that Black MSM report lower or equal risk behaviors compared to white MSM. However, we see higher rates of new infections. And as we know, the CDC recently released data that showed if data or if current trends continue in prevention, treatment, and care, that half of Black MSM will acquire HIV in their lifetime. So much of the work that has been studied by Patrick Sullivan and his team with involvement in Atlanta, we see that risk behaviors do not fully explain the variation in HIV incidence among white and Black MSM. Next slide, please. However, the behaviors or risk behaviors that are known to influence the transmission of HIV have not been adequately studied. And I think that this is where Perry has been talking about what are the factors that really influence and drive substance use. So what are even the underlying factors that lead to use itself? And so we see this work also highlighted in Greg's most cited paper, I think by now, by most HIV researchers, that show other areas in which we can study more to really understand the disparities between Black and white MSM. And so some of the work that we have showing or coming out soon out of Mississippi, it does align with the estimates and other studies that show Black MSM report equal or lesser drug or alcohol use, but we do see a higher or use of, that should be powdered cocaine among Black MSM compared to other MSM. Next slide, please. So in studying drug use behaviors, I wanted to give a slightly different perspective where we are looking at Black MSM in this framework of HIV environmental riskscape. So really understanding the risk and protective factors that shape the lives of Black MSM. So it's based off the socio-ecological model, where in the center, we look at individual level factors such as biological and behavioral factors. We've included intrapersonal characteristics. Next slide. And so then knowing that individuals are nested within social and sexual networks. So we've seen work that has recently come out by myself in American Journal of Epidemiology that shows the impact of sexual networks on HIV transmission behaviors. Next slide. And then we also consider public policy such as HIV criminalization that too exacerbates HIV risk behaviors on an individual level. Next slide, please. So I want to focus on drug use behaviors, but also look at it from a perspective of community. So really understanding the environmental and neighborhood level factors that can shape drug use behaviors. Next slide. So one context that has really began to get attention is spatial mobility. And so want to look at that in relation to drug use behaviors among men who have sex with men. And so work by Dustin Duncan, a colleague at NYU, and others have coined this term spatial polygamy. And so it shows MSM as well as others socialize and meet sexual partners outside of their residential neighborhood. So if we think about that in the context of where even ourselves live, we may know our neighbors very close with them, but we go outside of these networks to socialize and meet sexual partners that can be one, to not dirty or to air your dirty laundry is one of the quotes that was in one of Perry's slides. So that led to some of the work we've been thinking about and looking at that MSM may seek drugs or drug using partners outside of their residential neighborhoods. Next slide, please. So if we look at that, we may, next slide, that with this, the area that's shaded with the circle is where someone lives. And so if we look at it over time, we may traverse different neighborhoods, whether if that's to go to work, if it's to socialize at the local bar for a happy hour, etc. So we wanted to really look at this and inform some of our community work in Jackson, because anecdotally, we have been saying for years that Black MSM traveled the I-55 corridor, which is from Memphis, Tennessee to the north, Jackson, Mississippi, and central Mississippi down to the Mississippi Gulf Coast, or Biloxi, Mississippi, as well as they traveled the I-10 corridor from New Orleans to the west, New Orleans, Louisiana to Biloxi, and then over to Mobile, Alabama. And so we had heard a lot of this from our different work and just seeing where Black MSM hang out, just knowing it from the culture, like right now during football season. So last week was Jackson State against Tennessee State football game. So you had a large population or a large crowd for that game. You recently had Jackson State play Grambling. And so you have a lot of Black MSM that travel in particular to these games. So if we think about Black MSM in these larger contexts, and then thinking about the intersection of drug use to engage in sex, we can see how that may lead to risky sexual behaviors. And so we wanted to begin to put some empirical data to these anecdotal findings. And so we we did a small study of 100 Black MSM, 25 in Jackson, Mississippi, 25 in Hattiesburg, Mississippi, same 25 in Gulfport and New Orleans, to be able to, one, see if we can be able to obtain GPS data from these men, and then to begin to look at how these neighborhood level factors or exposures contribute to HIV risk. So as part of the study, we asked participants to carry a GPS device for 2 weeks. So they would come in during their enrollment visit, they would complete a survey and be given the GPS devices, about 2 inches tall and about a ½ inch thick, and they were instructed to carry it in their bag or pocket at all times, except for when they were taking a shower or going swimming. So they came back a week later to return the device. We download the data and complete another survey, and then they repeated that process 1 more week. So here's just an example of some of the GPS data from a pilot participant out of New York City. We could click that link. And so here's just some of the data, and you can see, well, we automated it. And so this participant is traveling back and forth to work right now. Then when he goes across the East River, that's to a sexual partner, then back across the East River to, I can't remember if it was a club or back to the sexual partner's house. So we can see the movement of this participant over a 2-week period. Next slide, please. So on this slide is a depiction of some of the GPS data from a participant in Jackson, Mississippi. And as you see there in the center, you have a higher density of points. That's the health corridor. No, go back 1 slide, please. Yeah, so that's where this individual's medical provider was located. And then you see a darker set of points on the right-hand side going north, and that was this participant's travel pattern for school. And so we wanted to dive a little bit deeper into this. And so we actually printed out some of these maps. Next slide, please. And interviewed participants and asked what were these points, what was around these larger cluster of points, to really be able to understand their travel patterns and begin to think about place-based interventions, or to see where risky behaviors were potentially occurring. So really like a social mapping type of exercise. So we see highlighted in orange, we see that that's their primary route to school. On the purple highlights is the route between his mom's house and his dad's house. And then we see upper in the northeastern region that's another way that they go to school. So, and there in the center again, we see that that's their medical provider. So we can see also where participants are spending a lot of their time. And so when thinking about that, of how then the environment or those social factors can really influence individual level behavior. So if they are socializing in a particular neighborhood or at one of the bathhouses, also seeing what that context is and seeing the drug use behaviors that are or that may occur in those settings. Next slide, please. So just one of the other pieces I wanted to highlight is just some of the anecdotal or conversations that, or information that we are gaining from conversations with community members, and it's the actual drug use or the drug practices. And so I know, well, this is work from or information from Jackson, as well as here in Washington, D.C., since I've onboarded the past 3 months that is helping us. And one is the actual combination of marijuana and antiretrovirals. And so we were really curious because we actually saw this in the HIV Prevention Trials Network 061 study that reported the presence of ARVs in HIV uninfected individuals. And so we wanted to, we just really started asking in one of our current studies about this phenomenon, and we are seeing a fairly decent prevalence of this occurring. Again, it's about the enhancement of drugs, and so I'll have more on that. I'm still very interested in learning more as to why that particular combination. Then the second is the booty bump, and this is some anecdotal work where Black MSM, I think the Black community overall, are afraid of needles. So they aren't wanting to inject crystal meth, but they want the delivery route to be faster and to have that same experience. So this booty bump is where they mix the meth in water, and in a syringe or a rectal dish or enema, they insert it in their rectum. And so that's another delivery method that is that is fairly prevalent among Black MSM. And then another phenomenon that we have been discussing or have been hearing recently is the delivery of powder cocaine in the eyes. And so a lot of this is the phobias, one around the needles, so hence the booty bump, and now with the powder cocaine in the eyes is the known fact of after prolonged use, you may have the runny nose, the bloody nose, so you don't want to be seen as a cokehead or somebody who snorts. So trying to think of another delivery method, as well as also in the rectum. So just looking at other methods of delivery and practices that Black MSM are engaging in. And so I think, again, this is oftentimes influenced by peer and social networks, where we see influencers of particular networks and the effects that it has on not only sexual risk behaviors, but also on drug and alcohol use behaviors as well. Next slide, please. So really, in taking this, we want to think about other prevention efforts. And so I know there's been work and interest in increasing methadone and Narcan availability. So with us helping us, we currently do HIV testing at many of the bathhouses located in DC, well, in the greater DC area. And so we are in the process of looking to be able to have methadone and Narcan on site in our mobile testing unit in the event of a drug overdose that may occur. Second is that we have to think broadly in that community-based organizations are truly ingrained in communities and can be locations for community level interventions such as Narcotics Anonymous. And so I know us helping us has been a leader in that, and we continue to support these particular efforts where we provide safe spaces for those who are battling their addictions. That feel comfortable, especially through these community-led efforts. And then secondly, to really sit and have a think tank around the drug use and HIV behavioral interventions. I know that with the advent of PrEP and the new information around treatment as prevention and U=U campaign efforts, we still need to look at and really get back to the question that Perry raised of why drug use. And so if we think about all of the historical traumas or our life or the traumas that we experience over the life course and see how that really impacts drug use and other risk behaviors. Next slide, please. But then also thinking about that at a more structural level as well. And so I know we as researchers or community organizations, we have particular ideas, but that may not be the most appropriate. And so really having community informed interventions. And so we really can't move the needle on this until we engage those who do engage in drug use behaviors or do have addictions to different drugs. And then also thinking about place-based or neighborhood interventions. I was talking with Kevin Jones, the executive director, about UCHAPS, about bringing some of this work to Washington, D.C. And while Greg was presenting, I was just thinking exactly that, this I-95 GPS study. So if there's any funders on the table or on the webinar, that's a great idea if you want to fund this novel study. But just thinking about looking at the I-95 corridor, where in the slide that Greg presented, where we see these increases in meth use in Baltimore, DC, and New York, right, and Philadelphia. So and then also coupled with what Perry said in terms, I think it was Bob who said it's really a weekend thing, right? So we can see how Black MSM may travel to these areas on the weekend and engage in these drug use behaviors. And so again, that's just an anecdotal observation until we do get this funded. And then also thinking about policy informed interventions. I know as researchers, we always say this in our last paragraph of a paper, saying how this can inform policy. But if we really think about what that means, and even with the legalization of marijuana, right, and then where there's all the different complications with that, where people engage in behaviors oftentimes when they're told they cannot, or they do it outside of their neighborhood so that others won't know about it. But if we begin to normalize particular drugs, or even get to the answer that to Perry's question about why even drug use, I think that we can really move the needle on these different factors that really contribute to HIV risk, and as well as use after serial conversion. I thought that was a really interesting slide. So that is all for me. Thank you again for having myself and the other presenters, and open it for any questions.
Awesome. Excuse me. Thank you so much. So we're gonna move on to our question and answer portion. First, I do want to let you know that there is a 30-second 2-question survey right in the chat box at the end of the presentation webinar. If you can just take a moment and just answer those 2 questions, that'll be great. So on to my first question. My first question is for Dr. Perry Halkitis. Are you still on the line?
I am.
Awesome. So the first question to you is, recording. Okay, isn't enhanced senses and physically feeling good a domain as well? I would not necessarily encapsulate that with social or emotional effects / drivers.
Yeah. So I think that there's like 2 sets of there's drivers and there's outcomes, right? So for me, the heightened sensations is the outcome of the drug use. When I talk about psychosocial conditions and realities, I'm talking about experiences in everyday life that burden us and then create challenges for us, like discrimination, racism, homophobia, and what have you, that then may impact the drug use, which then heighten the feeling, the sensations of feeling good, right? It's not a domain, but it's an outcome of the drug use. I think I answered that question. Did I? I don't know. It's not, I'm saying it's not a domain, it's an outcome. It's a loop in some ways, right? So the feeling good is a way of lessening or dampening the burdens that people are experiencing in their lives. Hello?
Hello?
Sorry, hello?
Hello?
I'm sorry. Yes, here we go. So this next question is to everyone. I would really like to know if there are studies that dig deeper into the sexual motivation to use meth, specifically if there are high incidences of shame and stigma about being the receptive partner in anal sex.
There are studies, this is Perry, there are studies about sexual drivers of meth use, seeking certain kinds of outcome expectancies of meth use that are sexual outcome expectancies. So there are, and several of our papers from CHIPS actually address that. I think your question about the receptive partner is a really, really interesting one, because one of the things that I think is at play here that I don't think we touched enough on about is conceptions of hypermasculinity and hegemonic masculinity and the extent to which gay men in general have challenge with this, but Black men may in some ways, because the way they're sometimes objectified by non-Black men, how that affects their conceptions of masculinity, which may impact their behavior. So I think it's a very relevant and important point.
Awesome. Thank you. And my next question is directed to Dr. Hickson. This question is about confidentiality and showing where someone's father lives in the study that you did. How is sharing this not violating confidentiality, showing where someone's father lives?
Yes, thank you. That is a very good question. With these data, what we do before we present them anywhere is to add jitter, where we actually mask many of the points, or we will layer a different mapping system on the actual points. So you raised that very good point. It's the same question that we had from the Institutional Review Board as well as participants, because some thought that we were tracking them real time and seeing if they were going to certain places. And we considered a lot of that because in a lot of these data and points, a lot of trap houses, a lot of drug houses, or places where they would go and purchase drugs were identified. And so that's where we began layering many of the maps with totally different street network maps.
I want to add something to this also because I work with Dustin on the New York City study. The guys were more than happy to carry their GPS around with them, right? And I think a lot of time was spent really thinking about confidentiality. But at the same time, they all did it. They all kept it on. They all brought it back. They were very happy to be part of something that they thought was so incredibly informative about their lives.
Exactly, and so you're exactly right, Perry. And when we added the qualitative piece, I think that opened up another window into all of this work, because we also asked about their experiences in these neighborhoods and these areas, and they talked about they were known as the gay guy at work, or they were seen as all of the advice when it came to anything gay, or even the drug dealers in one instance who protected one of the participants, and he was like, yeah, they're on the corner with their job, but they know everybody in the neighborhood knows not to mess with me, right? Because they feel that comfort. So again, that gets into yet another layer of where place matters. One who may not be a resident in that particular neighborhood may think that that's unsafe, but somebody who's lived there for a long time and then is known by the neighbors, they can see that as very safe and feel very protected.
Awesome. Thank you so much. Thank you all for your responses. If anyone that's listening, oh, wait a minute, I have another question. Regarding question 1 on domains, that is sort of a functional view on drug use. I guess I'm coming at it from an unqualified motivational perspective on drug use. Drug use could be an outcome, but not necessarily introduced any later than the other domain categories.
Okay. Yeah, I accept that. I think that's a good point.
Okay. All right. Thank you for that question or that statement. You're welcome. So great. So thank you all so much. I know we went over a little bit of time. It was so much great information. I couldn't end it. I hope you guys are okay with that. Thank you guys for staying on. The participants, this is great. I have a few announcements and I'll cut everyone loose. So next week, we will be having a follow-up best practices webinar. It'll be next week, Wednesday, September 27th at 2 p.m. This time, as I said, we'll be taking this time to bring jurisdictions that have been doing the work with the Black gay men, opioid and meth use to share, discuss strategy in ways to help other jurisdictions stay ahead of this hidden crisis. At the end of this webinar, once I log off, I'll be sending an email link to everyone with the flyer to let you know. And if you're interested in participating, please sign up and register. If you have any further questions, please feel free to email. If any questions come up at a later time, please email them to me at kenya@uchaps.org, or you can also text me at 202-945-2167. Just please let me know who your question is directed to, and I will forward them to our presenters to get an answer for you. On the screen, you'll see everyone that has been part of this webinar and all of our contact information. Again, I want to give a round of applause and thank you to our 3 great presenters. The information you guys gave was great and enlightening. I was over here. I had to mute the phone because I kept on saying, oh, wow. So thank you.